Thank you for joining us for the second webinar and our last webinar of the WeFunder series. I am the Chief Research Officer at Viit Health. I lead our clinical research and innovation partnerships across the US and Mexico, with a specific focus on bridging the gap between new technologies and real clinical environments. I'm also a proud Haverford and Penn alumna, which makes today's conversation especially meaningful to me. At Viit Health, our mission is rooted in the simple belief that we want a healthier world. We must close the gap between what is scientifically possible and what is a clinical reality. Yet innovation in healthcare is not frictionless. It demands rigor, humility, institutional trust, and a shared conviction that progress is worth pursuing even when the path is difficult. Today, with two leaders from Penn Medicine, I hope to unpack the perils and the parachutes that allow for responsible innovation to unfold. The perils being that which makes innovation hard, and the parachutes that which allows innovation to flourish. So thank you very much for being here with me today. I would like to start with a speaker introduction. Dr. Nalaka Gooneratne is an associate professor of medicine at the University of Pennsylvania. He specializes in sleep medicine and aging. He holds multiple leadership roles across Penn Medicine, including Director of Masters in Translational Research, Entrepreneurial Science Track, Director of Penn's Health mobile app and device services under the Clinical and Translational Science Award, and Director of Innovative Insomnia Therapeutics Clinic. As a fellow of the Institute of Aging and a member of the Institute of Translational Medicine and Therapeutics, his work sits at the intersection of clinical care, research translation, and technology-driven innovation across large academic health systems. It's a pleasure to have you with us today, Nalaka.
Yeah, thank you so much for the invite, and I'm really looking forward to the conversation.
Thank you. And I'd also like to introduce Ms. Rhonda Johnson. Rhonda is a nationally recognized nurse innovator, product strategist, and healthcare speaker with a career defined by human-centered design, cross-functional leadership, and unwavering commitment and empathy to health systems. As a registered nurse and a certified case manager, she works across emergency care, rare diseases, case management, health informatics, and product development. She internationally bridges the clinical floor to the C-suite to deliver strategic solutions for vulnerable patients. She serves on the American Nurses Association Innovation Advisory Committee for Data Science and Artificial Intelligence, and is a founding member of SONCIEL, Society of Nurse Scientists, Innovators, Entrepreneurs, and Leaders, where she has held roles including the board member and committee chair. Her design thinking facilitation work has impacted organizations such as United Healthcare, MIT Hacks Racism in Medicine, and the American Cancer Society. Since 2025, she has been adjunct faculty lab instructor for UPenn's Perelman School of Medicine, Masters of Healthcare Innovation. It's such a pleasure to have you here with us today.
Thank you. It's my honor, and I'm looking forward to a dynamic hour.
Perfect. Wonderful. So I wanted to start off by having a guided conversation. I also wanted to let our audience know that towards the end of this conversation, we will open up the opportunity for a Q&A. So there will be an opportunity on the bottom right-hand corner of everyone's screen. There are about 9 little dots, and a Q&A section will pop up. So around the last 20 minutes of this conversation, we will open it up to the audience so you can ask questions. Meanwhile, I would love for you to enjoy the conversation that we're going to have and to hear about the perspectives that these two wonderful speakers have today. So, Nalaka, I'd actually like to start with you with the first question. And I think that this will be important in terms of setting the groundwork about what innovation looks like today. So from your vantage point, I wanted to know, inside large academic medical centers, what makes innovation hard right now?
Yeah, I think that's a great question. And at the core of the innovation process is the concept of de-risking. That is understanding the barriers and challenges that might limit the ability to implement your innovation and your idea or the concept that your startup is hoping to succeed with. And that's why I think your question is very salient. It is really important to understand why innovation is so challenging in large academic systems, because that can help you figure out the pathway to de-risk and understand and anticipate barriers. ultimately, as we all know, a startup is a race against insolvency. So you're constantly worried about your budget and trying to achieve deliverables in time so that you can, keep your startup afloat. And anticipating in advance these major challenges or risks will help you to properly steward your financial resources so that you can make it to the next funding cycle, be that 6 months away, or if you're lucky, 18 months away. So what are some of the big challenges you need to know about in advance? Well, one of the main challenges is the long implementation cycle. I remember once working with a startup, and they were developing a web technology, and I didn't really see a lot of elements of their technology that I thought were patentable or that created kind of a moat to protect the investment they're making. And I also had concerns about them being able to implement. And the founder said that, well, he was very successful with sales at other when he'd been in management at other companies like at Amazon and at Facebook. So he had a pretty illustrious pedigree in that regard. But and he thought that he could crack the sales cycle. He thought that he could get into these health systems quickly, and he thought that he knew the tricks from his prior experience. And the short answer is, unfortunately, he wasn't able to achieve that. And luckily, he was able to sell the startup, and there was an exit that way. But it was still a challenge. And so it's important to anticipate that typically it's often an 18 to 48-month process, up to 3 to 4 years, to really get your innovation accepted or adopted in the health system. And so that's 2 to 4 years of no revenue, right? Because you're not getting any payment from that health system until it gets implemented. So you want to strategically plan for that and try to come up with other ways to keep your startup afloat that do not involve significant dilution of your equity. Another major challenge is that academic health systems or large institutional centers operate on pretty thin margins, maybe 1 to 3%. Now, again, their operating budgets are in the billions, so 1 to 3% operating margin is still pretty large, but there isn't a lot of leeway there for large or expensive setbacks. And the other key challenge is learning to integrate with the electronic health system. So the EHR is the 800-pound gorilla in the room, and almost all solutions nowadays are including more of a software component in them. Even many medical devices now have a software component in them. So that software component often releases data, and having EHR interoperability can be a major challenge, finding a way to get that data into the EHR. 60% plus of the market in the United States is controlled by Epic, so that is a logical place to begin. But working with Epic can be very challenging because they do engage in predatory behaviors, and that can be a problem as well. So these are important hurdles to keep in mind when you think about some of the major challenges that you're facing. And at the end of the day, talking to people who've been there before and have been successful previously are going to be really helpful in navigating this and might help offer you valuable guidance. So I'll stop there. Thanks.
What a fantastic response. Oh, I love that. That was very, very interesting. I agree. Time, money, margins, very important in terms of how you can consider your success. I think it involves a lot of patience ultimately. And I think knowing the reality of how long it takes to actually become part of a sector in a large institution, and actually getting this breakthrough into a clinical institution that's so large. I think everything that you just mentioned is key to anyone who's trying to go into the sector. So Rhonda, I actually wanted to, bouncing off of that, I wanted to ask you, based on your work in the intersection of nursing and product strategy and human-centered design, where do you see innovation getting stuck most often in these clinical environments?
Yes, thank you for your question. And much to what Nalaka has already said in terms of, EHR interoperability, I want to take it a deeper level and share some of the experiences I have. So working in a product development space, mostly in clinical software product development, clinical care services, and things that are actually reaching patients and patient care, either driving workflows or affecting the way that care is given to patients across the health systems. What I see oftentimes is a mismatch between your agenda and the timing of either the organization, their funding, or their fiscal objectives. So for example, you can have a great idea, you can have already proven efficacy and had a really strong case for it, but sometimes, you know, depending on the stage of the health hospital system or maybe the ancillary care service department, they may not be ready for that right now. And so the question is, are you, as a startup, as a software founder, are you willing to wait until that use case is actually pertinent for the business at hand? So there's that. I think mostly the barriers that I've, like, speaking specifically for like health systems, health and hospital systems, is really a lot of innovations, they go to die, so to speak, because there's a lack of true executive sponsorship. Somehow, oftentimes I see that there are contractual agreements, or someone thinks like this is a really great idea. And by and large, this could actually be the problem solver that we need for this department, this part of our life, this cycle, this startup, or this business entity. However, to face the headwinds without a true executive sponsor saying we are doing this, that becomes such a tangled mess. Not only that, but I think what I see hamstring health hospital systems the most, honestly, is their limited exposure to previous innovations. If you take a step back and you think about how antiquated, right, if I may say so, how antiquated health and hospital systems are as a whole, as an industry. You know, I oftentimes laugh about health hospital systems or healthcare as an industry, banking and education being very slow to adopt and move with change. Now, banking, we see some changes there, we see some movement, but healthcare is in this space where we desperately need change, but we are so frightened to grab hold of it. And it's less about risk and risk from the aspect of patients' lives, or we're going to hurt someone, as it is just getting someone to accept that change is needed and here is our answer. And so I think definitely we need to do something more with exposure to innovation and innovation frameworks. We need internal champions, and we have to definitely address these mindsets. That really is the bear in the room.
This is wonderful. This is fantastic. Thank you, Rhonda. I agree. I think that this makes a lot of sense, and I really love how getting both of your perspectives just adds on. And I think I have a final question about this particular section, which is setting the stage, right? So part of the discussion that we're having today, and this is to let the audience know how this is going to flow. We want to talk about the now, how things look like today in terms of the perils and parachutes of medical innovation that we have currently in our contextual history. And then we want to move forward to knowing how things will look like tomorrow. So as we talk about setting the stage, I want to ask you both, what feels different about the innovation landscape today compared to 5 years ago, just to fully contextualize how we're doing. So I'd like to ask Nalaka this question, and then Rhonda, I'd also love you to answer. I'd love for you to answer this question. So what feels different about today than it did 5 years ago? Are these the same issues that we had 5 years ago?
Yeah, I think a lot of the issues are fairly similar from ones that we had in the past. Many of these challenges are similar. The points that were raised by Rhonda, for example, and are very salient as well today as they were before. I do think that some things that do add to uncertainty are at least in the United States, are the current political climate, because the administration does, engage in new mandates kind of suddenly, which don't give a lot of institutions that much time to prepare. And so the bandwidth of many of the executives who might make the decision to adopt an innovation is now taken up with, kind of addressing the latest tweets that are coming out from politicians in DC. So I think that is one important difference between 5 years ago and now. Thanks.
I'd like to approach it in a different way, to just talk about how innovation landscape has evolved over the last 5 years. I mean, coming out of the pandemic, we saw an increase in interest in innovation, so much so that it became a buzzword and it almost became the new shiny object. But what I think has developed over the last 5 years is that we've seen real, tangible, physician-led, nurse-led medical innovations come to the market, either through ideation, facilitation, prototyping, and really, create value. So when we think about innovation, right, innovation is not like the next new big thing. It's not a great idea. It's an idea that transforms things and adds value and impact. And so when you have all of those things lined up and you actually see it come to the market and you read the white papers and you read the research articles and you hear about the newest buzz, that kind of normalizes innovation. And that's one of the things that I hope to do in my life, is just to continue to normalize innovation. It's not a new smartphone. It's not necessarily a device, but it's like, how do we do the most good with what we have and create something grand? And so I think the landscape is expanding, and I think that it's becoming more, at least people are willing to give ear to it, if you would.
Wonderful. Wonderful. Yeah, no, I like the idea of, even with the current political situations, knowing how we can get innovation to not sound like this new shiny object always, right? Because I think that speaks a lot, Rhonda, to what you were saying before, in terms of whether or not people trust things. It's the exposure to innovation that really matters. So I think this is a perfect segue to understanding a bit more of why innovation struggles to survive in these institutions, and to really talk about these perils and the hidden barriers, maybe, where it's either trust, alignment, incentives, risks. It could either even also be like systems in terms of workflows. And so, Nalaka, I wanted to ask you, in your experience, what helps clinical teams trust a new idea or technology? And what do researchers and innovators sometimes underestimate about building this credibility inside a health system?
Yeah, I think that's a really important point, that issue of trust and credibility. And I think there's a couple of important elements to really emphasize on that. As we mentioned earlier, it takes a long time to get an institution to adopt an innovation. And part of that is because of the need to establish credibility. And really, one of the best ways to establish credibility is through consistent long-term engagement with the leadership of the institution, so that they know that you're a reliable and safe option for them. So, keep in mind that when an executive or other individual within an institution chooses to champion your technology, they're putting their career on the line. They need to have enough faith in what you're doing that they're willing to take a hit in case things don't go the way as expected. So if they roll out your solution and it doesn't work well, they are the ones who get blamed. And that's why so many of these institutions adopt Microsoft products, which are generally pretty crappy, and yet we have to use them because they're the safest choice for the executive, right? Because if they took a risk and they went with something from Zoho or some other smaller player and it doesn't work, well, then their career is going to get hit and they might not get the next promotion, etc. So they need to have faith in you, that you're going to be around for the long term. And let's face it, because startups are, as we mentioned before, in a battle against insolvency, startups are not the best bet for that risk, right? So you really have a pretty big hill to climb, but there are some strategies which you can use to help you succeed in that. And one of the most important strategies that I recommend to a lot of my trainees is to really understand the person at the other side of the table who you're talking with, and that understanding centers around asking a couple of key questions. Like really asking them, what keeps them awake at night? What is a central problem that they're really struggling with, that they worry about constantly, because that is a priority for them. And then you can try to see if what you're working on kind of can align with what they are really what's really top of mind for them. And then you also want to approach your engagement with them in a very kind of open and curious manner, not with an agenda you're trying to push, because then they'll immediately recognize a sales job and they'll start losing trust with you. So you really want to try to understand them, their perspectives, and really kind of build that human connection. Now, many people discuss the benefits of collecting research data, and it's absolutely true that having evidence to support your intervention is important. But I want to warn you against the trap that sometimes people fall into, where the institution they're trying to negotiate with ask for more data, but in reality, it's just a stalling tactic. And if you fall victim to that, then you're going to run out of funds while you're trying to collect data which they pretend that they want, but they don't really want it, and they just want to get you out of their office, basically. So again, if the problem that you're addressing is top of mind for the individual, they will make it happen. They will make steps forward. But if they say to you, "We need more data," they're probably just trying to get rid of you, frankly. But nonetheless, it's still informative, and you could still ask them what kind of data are they interested in, what kind of hypothesis, what kind of numbers would they like to see, etc. And at the end of the day, most executives are trying to find ways to fire employees. That's the bottom line, right? So most companies want to cut cost by finding ways to fire staff. So because that labor is one of the most expensive aspects of any kind of healthcare enterprise. And so if you can show directly how there's a reduction in need for staff from your innovation or your solution, that will be a very clear kind of quarterly benefit for the person that you're negotiating with. It's kind of a harsh truth, but it is the reality of a capitalist economy. That's just kind of how things function, and it's important to be aware of that. And then the last point I'll mention briefly is that while I did say that you have to be careful about how much research you engage in, I do think there is a benefit in trying to do a pilot research intervention at that institution, because then if clinical adoption ever does occur, you have facilitated the clinical uptake, because now you've integrated with the EHR, which is a point that I brought up earlier. And in this regard, you want to generally stay away from the large academic institutions like the UPenns and the Harvards and the Yales, because they're very slow. They have a lot of research going on already. And your best bet for penetration is the mid-tier institutions that are hungry for innovation because they need a competitive market advantage. Penn doesn't need a competitive market advantage. Penn has the market in Philadelphia. But a mid-tier institution is struggling to gain shares and might be more receptive to your innovation. So I'll stop there. Thanks.
Phenomenal. Thank you. Rhonda, so I'll ask the question directly to you to see how we can bounce off of this. So as someone who bridges the clinical floor and the C-suite, how do you see that you could build alignment across clinicians, leaderships, and operation when introducing something new? So how do we build this trust, and what are the human and operation realities that innovators need to understand? And thank you so much, Nalaka, for your answer.
Yes, that was extraordinary. And I'm definitely nodding very fiercely over here because it's 100% congruent with my experiences across most projects in every area of healthcare. So that was great. I think what I can begin with is to begin to answer your question by just telling people simply preparation and understanding the landscape of the company and the key players. So it's really important to know who wants this to succeed, because you always have a few. But it's also equally important to know like who is going to stand in your way and who's a little bit neutral or can care less about it. And unfortunately, based on some personal and professional experiences, some of those people might take you by surprise. Some organizations, they are in need of your innovation. They are in need for you or someone externally to come in and solve their problems, but they themselves are naive and they don't understand what they're focusing on this year for their North Star. Or perhaps the C-suite is not 100% aligned on their strategy. Right. So now you're talking about misalignment from the top, and then someone from within now trying to create a compelling story about how this widget, document, workflow, software, and medical device is going to make everything better in the grand scheme of things. I will tell you that some of the biggest barriers that I've experienced recently has been through engineering teams, which is laughable because you would think your software development teams would be savvy and understanding how the component is actually going to support the business enablement, achieve the goal, right? Make us more sustainable. But I think that alignment, that misalignment, like much to what Nalaka said about blowing smoke and delaying you with like asking for more and more data and more research and more proving and all of the things, I've seen that happen. More components and more this and what if, and a bunch of hypotheticals about, well, if we do this in 24 months, how can you address, right? And so we have to be zoomed down on the now and leave room for the future. So What are some successful tips? Obviously, Nalaka spoke about building trust. There is a huge mistrust in technology right now, mostly because of, like he mentioned, the salesman's approach. I can't tell you how many former PayPal, Twitter, text, and that's not not downing these companies, but they've come into the healthcare space saying, we've done this very successful thing with non-clinical, like non-patient care human stuff. We know how to sell, we know how to combine databases, we know how to push a initiative forward. And they come in with this machismo and this energy and this ego and this brain, like, we know what's right for you, without speaking to the first clinician, without touching base with nursing and medical leadership, right? And just throwing their ideas on top, and then it going wrong. And that's the thing that people are always going to remember, is what went wrong. Is we asked for this last thing and it didn't do what it was supposed to. Probably because we didn't interview the right people. We didn't use design thinking. We didn't touch the right people. So building trust is very, very important. And then maintaining that trust. Also, it's really important to show successes along the way, whether you are trying to just do a proof of concept, a pilot, a beta, or a full implementation through phased things. You have to show the success of every step, and that means creating a phased approach. And that kind of brings me back into like the way that you get away. Like, this is a cheat sheet, like a cheat tip here. The way you get around that constant request for like more data, what if, right? Because I've seen software teams in companies talk to startups saying, we want this, and then the startup company being very responsive to say, well, we can build this component and then we'll do the thing and we'll show it to you. And then by the time it comes back to us, now we want something else. Our objective is pivoted to something else. Or maybe it doesn't do what we thought it would do, right? But all of that stuff should be tested inside of the internal pilot, right? So create your proof of concepts, have a very strong proof of concept. Let's talk about pilot plans. And then for adoption, come to the table with a clear path to adoption. Clear, like, it's not let's load it up and then start figuring out how we're going to do this. Come to the table prepared 100%, and that will navigate you through some of the sticky stuff.
Wonderful. Thank you. Thank you. Thank you. I think that's a very complimentary view. And I think that makes a lot of sense in terms of what you're talking in terms of big sized institutions that already have probably their plate filled with innovation research and a bunch of things going on. And then what it actually takes to build that trust and to have that collaboration. And I think this is a fantastic cheat sheet for a lot of people who are trying to enter health systems, right? Because for a startup, and I think some of the things that we were mentioning is, we do tend to have antiquated systems because of trust, right? Because these are systems that we trust. These are medical devices that we trust. And so how do we create this new trust with a new wave of innovation? And that means reliability, right? And making sure that this trust is being maintained with the people who are creating this innovative solutions, and making sure that they're talking to the right people and that they have the right endorsement. So I'd like to ask about the parachutes. So we already know a bit about like the perils, the difficulties, and and Nalaka, you mentioned this, right? We live in a capitalistic society, so it's good to get these ugly truths out there, because those are part of either the perils or the parachutes that could lead the way, right? So I'd like to start with Rhonda this time. And so Rhonda, you speak about human-centered design and operational empathy. And so where do you see these parachutes, these safeguards, structures, or habits that help promising innovations survive long enough so that they can demonstrate the real value for patients and clinicians? So I don't know if you have an example, perhaps, of an innovation that's successfully been able to permeate the nursing environment.
I'm sure a story will arise in the response here. But in terms of parachutes, like the things that are actually undergirthing and helping our innovations to survive, I think that I've kind of introduced that principle in the last response, which was about the phase rollouts, right? Everything has to be iterative. Everything has to be not siloed necessarily, but, broken down into measurable chunks of value, so that we can make sure we're on track, make sure we're doing the things that we needed to do, and then also that value is captured on the receiving side. With that said, I think a lot of startups, or I think just external vendors as a whole, they a lot of approaches that I see go wrong is that there's no contingency or no discussion about monitoring and tracking. So, what are we monitoring? First of all, did you set up your baseline things internally in the company? Have we established a baseline of what X is doing? And then, how do we plan to measure change in delta for that particular objective? And then how are we going to establish real-time either compliance monitoring or real-time tracking, so that when we experience an improvement or a decline in a thing, which neither are bad, neither is bad or good, right? That we can be responsive to something. But I think really what I've seen most helpful in innovations is just partnerships. Partnerships are so important. So when we think about how hard it is to actually get a software item or initiative or just an innovation inside of a health or hospital system, you have to rely on relationships, of course, and then also through relationships and partnerships, it makes it a little bit easier. So case in point, there's a health system that I work with in Pennsylvania, which is not Philadelphia, but in Pennsylvania, that they have an amazing partnership with an academic university, a community nonprofit, and then also their own internal innovation research hub. And so together, they sort of spread the risk, they de-risk things, and then they also are all using their brain trust to move a thing forward. I think that we're in a time and place economically and through the current administration where so many hospitals and health systems and companies and even big tech, they're just bleeding funds. I mean, we're seeing things closing down and shutting down, and people are having to make very strategic decisions, also short-sighted decisions. So when it comes to innovations, you really have to come to the table very, very strongly with some strength about the value and the promise that you hope to deliver. And those parachutes often come from just, again, setting yourself up very well. I live in Houston, Texas, and what I think about, like, we have an innovation district here. We have TMC, right? We have Texas Medical Center. We have acres and acres and acres of medical systems where there's the MD Andersons and the Houston Methodists and all of that. And I'm in meetings every week where these hospitals are actually hungry for innovations. Like, they are begging the community for their ideas, from patients, nurses, clinicians, and all of that. But what they don't have is they don't have companies that are ready to pilot. They have people who have ideas. They have people with things in sandboxes and development, but they don't have even anything beyond a proof of concept. They don't even have a prototype, right? So when you think about parachuting, I think it's about the strength of being ready to engage, because there's not an issue for funding here. They want, and they are hungry to pilot. They're saying, come through the door. So I think that's really, those are kind of key.
Phenomenal. Yeah, no, and your experience ultimately being able to see these people, in these institutions that are hungry for innovation, I think that speaks loudly to what's necessary, right? And what's needed in the sector. And so, Nalaka, I wanted to ask you as well about the parachutes that you see. And I was even going to ask you, like, if you could build one mechanism or support system that every health system should have to promote responsible innovation, whether it's a process, a committee, a metric, or a mindset, do you have something in mind? And what do you see are the parachutes truly for innovation in these health systems?
Yeah, I think that's a really valuable question. And I think Rhonda brought up some very important points. Ultimately, the best parachute is money. So hopefully you did enough fundraising in your Series A or B or C that you have some runway. That is the best parachute. But other really valuable parachutes, as Rhonda was bringing up in her discussion about partnerships, is really growing those. And I'd like to suggest that there are 5 possible kinds of partnerships that one could explore. And these include some kind of pilot funding mechanism. Some universities have, or health systems have, pilot funding mechanisms. And to your point earlier about what one mechanism should an institution have, it would be some kind of innovation hub in the institution, where an organization or entity in the hierarchy of the org chart, which really has that as their mission, supporting and accelerating innovation. So you would want to be looking for that innovation hub or center and engaging with those individuals, and hopefully they will have some funding mechanism that could be tapped into to create some of that partnership. Other valuable partnerships you could explore are clinicians who might be interested in doing some kind of QI type intervention, and that could be valuable because that could help get you into the workflow of the institution. There might be different executives and individuals that you might also want to connect with, and an important indicator that you're creating a partnership with that institution is that the institution is willing to allow you to meet with these people and is helping to set up the meetings so that you are able to connect with various leaders within the institution. If you find that you're being siloed and you're only being told to talk to one person, that could be a bit of a red flag that a partnership is really not developing well. If that one person had faith in you and really thought that this could work, they would be introducing you to other people, not just kind of constraining your access to the institution. A fourth tool that you could leverage for partnerships is researcher engagement. Many of these large institutions, especially academic institutions, have researchers who might be hungry for collaborative projects, which they could then present as an abstract or something at an academic conference. And also, as Rhonda had mentioned, many large health systems are looking for kind of community partnerships as well. And is there some kind of community organization you could work with and sort of get a buy-in for a partnership that way? Ultimately, these partnerships need to have measurable milestones. You need to have a next step in this development pathway, and if your partner is not achieving their end of the deal, you need to start looking elsewhere, because that could be a sign that it's just not going to pan out ultimately. So those are some thoughts as to some strategies to help support responsible innovation and create a bit of a parachute for some of the risk that you as a startup are taking by investing time and effort into an institution.
Phenomenal. Thank you. Thank you so much. I think that also being able to talk about these 5 different strategies for partnerships are really, it's very meaningful to a lot of people who are starting, to enter the medical field. And I think that's what really creates that trust that we were talking about. And so I want to ask the last couple of questions, or enter the last section of our discussion before we open it up to the audience. So for those in the audience who might have questions, I'm going to be adding a section right now so that you can see where to ask the questions. It's in the bottom right-hand corner. There are 9 dots, and so there's a Q&A section. And you're able to ask any questions there, either anonymously or publicly, and then I can ask that to our 2 incredible speakers here with us today who have given us their time. So for the last section, talking about the future, bringing it all together, everything that we've talked about so far, I want to expand the lens of what are the opportunities for impact for the next decade and for the future generations. And so I'd like to ask you, Rhonda, from the perspective of nursing innovation, where do you see the biggest opportunities for meaningful impact today? And what do you think about future generations, and where can innovation improve care for patients as well? So how do you see this going?
Yes, I'm very excited about this question. One of the things about nursing innovation is that it's its own specialty of innovation that serves both the nursing community, right? So we can innovate for other nurses across healthcare, but also really the center core is innovating in ways that benefit patient communities. So there is that tie-in. It's a yes and situation. And you bringing up patient-centered design is so key in this area. As you think about healthcare industry, right? Despite the youthful face, I've been around for a long time. I've been in and around healthcare for quite a little bit here. And it really grieves my heart to see what we're facing in this hour, in this day. Particularly when we're looking at a nursing shortage and hospitals and health centers closing. It seems like every other email, I'm getting some kind of news brief about some clinic, some department closing, some major hospital, right, doing this or, releasing their employees and things like that. So when you think about nursing innovations and patient-centered design, things that I'm really excited about, I think we've hit this critical inflection point where I sit in meetings and I hear about really cool technologies all day long. I hear about space age stuff. I live by NASA, right? I think we really have to battle down and do two things. We have to figure out how to innovate to bring care to the people who need it, and bring education to the patients who need it as well, because there's such a gap. If we think about how there's the loss of access, insurability, we're already constrained with the limited amount of primary care physicians or even specialty appointments and all the things. Telehealth is being removed, right, from our rural communities, our Medicare, retirees, our senior adults. My heart is just, like I said, it's just so grieved on how many people are going to go without care. They're going to go without screenings. They're going to miss, right, the subtleties of something that could have been caught. And then by the time it's diagnosed, it's like, oh, you're beyond, like, this certain phase of care. So what do we need? We need innovations that don't just plug holes, but that sustain. Because I think that, for the rest of the next 3 years of the current administration, that we're going to continue to see an increased acceleration of the removal of things. I don't think we're going to like turn back and say like, oh, let us restore. If anything, I see we're going to take away more. And so as a population who has to use a system, healthcare is so unique in that we're all going to be consumers of it. You understand what I'm saying? Like, we're all going to touch base with some health or hospital system, whether we want to or not, ourselves, our family members, and all that. So this is why it's very crucial. I will tell you about my personal career. I am a nurse and I've got a lot of letters behind my name, but there was a point in my career that I became very uneasy with what I was seeing, right? And so I wanted to learn more about how to leverage data sets and analytics. And so I thought I would take the easy way out and I'll just take an analytics course. Lo and behold, I understand that this was actually a journey into data science. And why is this important? Because I wanted to be able to examine and learn data sets and pursue the outliers that we do not use in general algorithmic things, right? So we're all building technology and we're developing new approaches to address this patient population or this disease, or, reduce or amplify these measures. But we still live in a world where clinical research is using, let's say white women from a certain age to study breast cancer, when we notice that Black women from the ages of 40 to 50 are more disproportionately affected by the condition, right? So this illuminates two things. One, of course, there is a pressure in clinical research to make it successful so our product can get to market, right? But then I also feel like from a human-centered design perspective, from a human equity perspective, from a social justice perspective, that we still have to meet the needs of patients. And so from human-centered design, patient-centered design, I think we need to get down to patient engagement. We need to include them in these conversations when we are building things, considering things from the jump. Don't build something and then hand it to someone and say, how's this going to work for you? I think we need to pull in clinicians earlier, soon, as we say, often and early. Every product team is heard, often and early, right? We need to set the foundation very, very strong from the beginning, because we don't have time. Like, we don't have time. We don't have money. We don't have time. And things are going to get critically, like the future that I see, we are going to get critically, it's just going to be a hemorrhage situation. And I just don't know even how clinicians and healthcare providers are going to survive this. I think morally, ethically, financially, I see even bedside nurses losing their job at this time. It's just a really tough time. So if we can do something to innovate, to get the care to the people where they are, and it's all people, it's not just those with the smartphones, right? Innovation is best when you're meeting the people with the least. And if we can educate patient populations on what to know, look for, how to take care of themselves, maybe that would be a parachute or a buffer, so to speak, to get us through this next ugly patch. Thank you.
The truth sometimes hurts, right? Yeah, I understand. I definitely think that that's why we were talking about the importance of the historical context, right? And how this looks in the long run, right? Like how innovation has looked in the last 5 years, how it looks now, and then what it looks like in the next 5-10 years. And that means how our systems, our health systems themselves are working and what their pain points are. And so, Nalaka, I'm curious, looking ahead for the next 10 years, what shifts do you think will define the next decade of healthcare innovation? And what do you hope the next generation of clinicians and innovators will prioritize or do differently? And Yeah, I'm very excited to hear what you think about this. And then we do have some very interesting Q&A that we'll move into.
Yeah, I think Rhonda brought up some very important points about social justice and the need to make sure that the least served in our society are receiving optimal health care. And I'd like to present a slightly different perspective on it, which is that perhaps we're actually living in a time where there may be incredible opportunity to improve the care that people receive. And this, of course, will depend upon the decisions that are made in the near future, but there are some very meaningful innovations that could really accelerate this opportunity to provide improved care to those who traditionally and historically have least received the care they deserve. And I think some of these transitions are related to AI. And NVIDIA's earning report came out pretty positive, and the market is recovering a bit from its disastrous week. And we'll see how that story unfolds. But ultimately, AI is going to have a transformative effect. These tens of or hundreds of billions of dollars of data centers that are being created around the world are going to have an impact. And this impact is going to manifest in drug and device discovery and innovation. You know, the advances in protein folding and in genetic markers and so on are just mind-blowing, and they're going to really trickle down in the next 5 to 10 years. It's not going to happen tomorrow, but it is going to happen in 5 to 10 years. And I definitely see a lot of potential for so many diseases that have really plagued us and other communities to really be meaningfully improved. And then I think another really salient point that Rhonda brought up was around bringing care to where people are. And I think we are going to see major advances in home care. I think telehealth is here to stay. I think many people will be upset if it's revoked by Congress. And I also think that robotics is going to have a transformative effect in the home care environment, with robots potentially costing in the 10 to 20K range and being augmented by AI. It can really help to address the shortage of medical assistants that exist. And then lastly, in the clinical decision support space, it's very valuable. Yes, we all know of doctors and clinicians and healthcare providers and nurse practitioners and others who are incredible clinicians, but they're a small minority of the provider pool. And the majority of providers are ho-hum or maybe not optimal. So clinical decision support will allow us to elevate the floor of support these providers get, so that everyone, even those who are traditionally least able to pay, will now have access to really top tier medical guidance and input. So I'm quite optimistic about that. But I do want to warn you, as someone who was group individuals who are thinking about the startup space, just to be cautious about that phrase value-based care, which insurance companies love to throw out there. And I kind of think that's just virtue signaling and performative rhetoric. Insurance companies have made almost no movement towards value-based care, but they do love to discuss it in their presentations. And so I think that the traditional fee-for-service model is just so lucrative for the insurance companies, it's unlikely that they are going to move meaningfully towards value-based care. So just be a little bit warned about that. I've been hearing about value-based care for the 30 years that I've been working in healthcare, and I just have seen almost zero movement towards it. But maybe I'm wrong, and it would be nice if it did happen. But at the end of the day, I am very excited. There's a lot of tremendous opportunities, I think, in the future.
Wonderful. Yeah, no, and I definitely agree in terms of like what we see can be the perils and parachutes of the future as well, right? In terms of there are some technologies that I think are very promising, and the idea is that they don't just end up being value-based care, something that's being included in presentations and not being done. So I want to move now towards the last 10 minutes of our discussion and include the audience and their wonderful questions. So I think there's one question that I would love to ask to Nalaka, and then I'll move on. There's a particular question for you, Rhonda. So Nalaka, Evelyn is asking, how is the perceived pace of innovation and instant access to information influencing public mindset? And I think this is a very interesting question.
So if I understand correctly, you're asking how the perceived pace of innovation and public access to information is improving and influencing the mindset. And so I think that unfortunately it's leading to a lot of confusion, and people are essentially finding something somewhere on TikTok to support whatever bias or view they might have had for whatever reason previously. And that does lead to a lot of misinformation and misunderstanding. As you know, with AI, one of the biggest challenges can be that AI can be sycophantic, and it can just sort of feed you what you want to hear. So it'll just start showing you information that you want to hear, and it'll lead you down that rabbit hole, because that way the AI platforms get increased engagement. You keep coming back to them because it's validating your ideas. And so that is the big challenge. And I do think that healthcare providers, nurses, and clinicians really, and physicians really have a very important role in kind of speaking up and advocating for evidence-based solutions or answers.
Yeah, I agree. I do think that it's becoming an echo chamber, a bit about like what your thoughts are, and then that's what it will feed you. So I do agree that there is a confused public mindset. Rhonda, Muratha from our Q&A is asking that you talked about how the goals for executives can switch rapidly. So how can a feedback loop be created that is not overwhelming and that is agile to pivot? What type of people should be involved in that loop?
Wow. So that is a great question. And let's see how we can approach this. I want to set the stage by saying, to understand that development teams and business objectives that businesses are working on now have been decided last year, right? So the things that we're focusing on today, we discussed back in 2024. Now you set up the situation where a new opportunity comes about, and we really do need this software component. We need this medical intervention innovation. The question is, how can a feedback loop be created that's not overwhelming? Well, the truth of the matter is that there's this constant shift in priorities and opportunities. There's this constant weighing of, is what we are doing worth continuing doing, which we know that there's a sunk cost in proceeding with things that should have been decommissioned a long time ago. But the idea of something being like, the way I explain it when I work with the engineering teams is like, the train has left the station, right? The train is left. We're at a certain speed. We have to keep going. And the reality of the nature is that at any good point, an executive can and often does come in and say, let's stop this. Let's change. Let's pivot. So you ask the question, how can feedback loop be created that is not overwhelming? The feedback in terms of, like, I need a little bit more information there. Because what's happening from an internal standpoint is that a project is going on. Executives are getting their quarterly, weekly, monthly reviews, their updates. They're up to date on all the things. It's just a matter of like holding the line. It's just really like reiterating why we selected this, why we're doing this, where we are in this point of development, what we hope to get, the gains that we've gotten so far, and the expectation. It's like, you put in an order for food, you're expecting the steak to come, the steak hasn't come, but you're still hungry, you're thinking, maybe I want chicken. You have to hold people accountable to the decisions that they've made, and just continue to just repeat and repeat and repeat, like, this is why we're doing it. But also to let them know, when you stop this initiative, you're losing all the investment. You're losing the time investment, the resources, the money spent, because development costs money. I worked on things that were easily $150,000, $100,000 or $500,000 a quarter of development costs, So when you think about what type of people should be involved in that loop, obviously you have the executive sponsor, you have the C-suite person who's either trying to pivot or object. You have your internal champions, you have either your business development people or your product management, or, if you don't work in a robust place that has product management, you might have a project manager who's actually sitting in that seat, but you really have to get some strong voices. I have no shame. There's been times that I've tapped on my medical partners. I've called the CMO and said, look, we really need to push this through. Can I get your voice and you back me up in this meeting? You have to have not only the positive relationship with the people to say, this is what we're doing and here's why we're doing it, but you need some strong soldiers beside you to say, no, she's right. Like, this is what we need to do. We need to press forward. Sometimes people will give ear to someone who has either higher status or maybe longer tenure in the place, but it is very, very difficult. There's really no answer, but please understand that this internal pivot, it's constant. It's constant. It's constant.
No, I agree. I think that there isn't that feedback loop pre-established. You have to create it along the way based on how things move, and it's very dynamic. So we have a couple of minutes left, and I'd like to integrate two questions into one for both of you and see if we can kind of just touch base on this, and then we'll do a little bit of a closing. So Gabriel asks, how do you leverage rapid medical innovation without compromising public and individual health? And I think this has a lot to do with what Ivan asked. So how do you leverage medical innovation without compromising the individual or the public's health? And especially considering the current administration and how it's big on deregulating a couple of things, so it removes some crucial funding from healthcare. How do we consider these two things, right? And how do we create medical innovation within this context without compromising public or individual health? So I'm curious what you think, Nalaka, and then Rhonda, if we can go with you as our final thoughts for the day.
Yeah, I think that's a really important question. Thank you for asking it. My answer would be to listen to healthcare providers. So to talk to the frontline nurses, the other clinicians in the space, and get a sense of how they perceive your innovation and how you're marketing it and how you're approaching it and how you're rolling it out. And that will be a really valuable litmus test for whether you are crossing the line. In the startup space, there's a lot of pressures that we face in terms of the investors, the timelines, and so many other burdens and challenges that it is tempting to try to accelerate things, which ultimately might compromise public trust. But if you have an open and inquisitive mind as you engage with healthcare providers, that can serve as an important check to make sure that you're not crossing any boundaries.
I would like to take it from the standpoint of, to Ivan's point, this current regulation, the current administration is big in deregulation, which I think is under the guise of trying to accelerate more products to the market. However, I want to combine that with the earlier conversation about leveraging rapid medical innovation without compromising public health. The 5 stages of design thinking includes the last 2 stages is, prototype and testing. So, given that medication, like the medical field is highly regulated, you move in stepwise iterations, essentially. You have to put something out there, make sure that it's doing what it needs to. It's not creating additional harms or unintended consequences. Then you plan to scale, scope, and increase. And so we have to balance both the removal of layers that, might have taken research too deep, like taken too long for us to research, but then also, considering that the FDA and a lot of other agencies have lost their voice in the say of things, just proving efficacy, without harm.
Yeah, no, absolutely. So I want to take a second to thank you both for this incredible discussion. I think it's a very fruitful opportunity to start thinking about not only what the past has looked like, what things look like right now, but how the future will look like. And I also want to thank the audience for their questions. And Ivan, you left me a lot to think about, because I do think that we still have to recognize that we have some mechanisms in place that will hopefully allow for good innovation to thrive. But that doesn't mean that we're not fighting against what's happening, currently. So I think it's about the mechanisms that are currently in place and the ones that will thrive, and making sure that we push that way. So Nalaka, Rhonda, thank you for your insights and your candor. Today's conversation really reinforces the core truth, right? That innovation succeeds not only because of great ideas, but because of great systems, aligned teams, and the willingness to build trust. And at Viit Health, we're very interested in engaging in this conversation, because I think it's imperative for how we can improve the care that is delivered to patients and to communities, no matter where they are. So I'm very, very thankful to all of you, and I hope you have a wonderful day. Thank you so much.
Thank you. Bye-bye.
Bye.